Welcome to Grand Rounds. I guess we'll get started. This is the 14th annual Schisgall lecture, and Richard Schisgall was a pediatric surgeon in the D.C. area for many years, who was a consummate pediatric surgeon who primarily practiced in Holy Cross, Silver Spring area, but also brought many of his cases here to Children's. We've established this lectureship, and over the years have invited surgeons and practitioners to talk about their expertise in areas. This year we did a little bit of a change and have a prominent gastroenterologist and pediatric gastroenterologist to talk to us. Carl D. Lorenzo is professor of pediatrics at Ohio State, where he's the chief of the Division of Pediatric Gastroenterology. He did medical school in Naples in Italy, and then did a couple of fellowships in Belgium where he studied pediatric and adult GI disorders. Then he moved to the West Coast, where he did his training at USC and Harbor, UCLA for pediatric gastroenterology, and then eventually went to Pittsburgh, where we overlapped, and I got to know him very well. And Carl is just an outstanding doctor and a great individual to know. He's co-authored the only 2 textbooks in pediatric motility disorders. He's got many publications. He's the current president of the North American Gastroenterology Society, and he's very modest and humble. He'll never tell you any of these things, and you just get to know him, and he doesn't ever talk about himself, but he's quite accomplished. He recently received the Master of Gastroenterology award from the AGA Institute, and again, he's just an outstanding individual. I'm very happy to have him here, and he's going to talk about what's new in motility disorders.
Thank you, Tim. Let's see if I can turn this on. Hopefully you can hear me now. I'm not sure you can understand me, but you can hear me at least. It's a tremendous pleasure to be here. It's one of the premier pediatric institutions in the country, tremendous surgical department, tremendous GI division, one of the top in the country. And it's kind of a little funny for me to talk about motility disorder. You guys have one of the experts in motility that leads one of the best motility centers in the United States, Dr. Darbari, but I'll try to share with you a little bit some of the novelties in motility disorders. This is my disclosure slide. I have 3 companies with whom I consult, and none of them makes products that will be discussed today. But I will discuss many off-label use of medications that have been approved for different use that we use for motility disorders. All right, I'm going to start with a quote from one of the biggest philosophers of the 21st century, Dilbert, who says, I like to start a cartoon. It's about a guy who shows a cartoon before giving a boring presentation, but the cartoon doesn't work because there is no punchline. Kind of, I'm afraid, that summarizes my talk. All right, so what I'm going to talk about? I'm going to talk about the clinical presentation of motility disorder, the spectrum of motility disorder, some of the differential diagnosis, and then some of the new tests, some of the new toys and tools that we have, and then we'll talk about medical therapy. I'll try to discuss a little bit of surgical therapy. I've been invited here by the surgeon, so I'll focus a little bit more than I usually do on surgical therapy. And there is no number 6 because 5 is plenty of things. An announcement. It's a great time to be a pediatric motilist. You know, a few years ago, that was not as much fun. We didn't have a lot of drugs. Cisapride, for those that have been around for a while, had been taken off the market. Most of the medication were not being deemed effective enough to be FDA approved, and we really didn't have a lot to offer to our patients. But now we have less invasive tests. We have better drugs. We have gastric and sacral nerve pacing. We have surgical interventions that have changed the quality of life of our patients. So it's a lot more fun. We have something we can do now for patients with motility disorder. And why do we need to treat motility disorders? There is a fact that the most important task of the GI tract is to move its contents from one extreme to the other. It doesn't matter how well you absorb or secrete or or, have a hormonal changes or anything like that. Nothing matters unless you're able to move things from the esophagus to the anus, right? If everything stays in your stomach, you cannot absorb it. You cannot take any advantage from it. So motility is the main task of the GI tract, hence the importance of this talk, so pay attention. So who are the patients that we take care of, right? The patients are like this little girl, Brandy, who came to see me for an evaluation, and when you look at her, she looks pretty normal. And she looks like a child that has, maybe a little puffy face, but otherwise looks pretty healthy, able to talk and walk, and actually goes to school. And she plays softball, but does not have lunch with her friends because she has pseudo-obstruction. And if you have pseudo-obstruction, once you take your clothes off, that's what you look like, right? You have pseudo-obstruzione in Italian. You have a G-tube, a J-tube, an ileostomy, a central line, and a vesicostomy if you have a bladder problem as well. So you have a variety of different interventions that the surgeons have made that allows you to stay alive, to stay reasonably healthy, but of course you have some limitations in what you can do and how much you can eat. And pseudo-obstruction can be considered like an extreme of a continuum of motility disorders. When I talk about pseudo-obstruction, I then tend to lose people because they say this is a rare disease. I'll never see another patient like this, or maybe the GI folks take care of them. But actually, pseudo-obstruction, okay, is extreme, is the tip of the iceberg, right? But there are a lot of milder forms of motility disorders that you will see in clinic, or you will be consulted on if you are a different specialist. And and also dyspepsia and bad reflux or bad constipation. When does one end? Where does the other one begin? There is an overlap between mild form of pseudo-obstruction and patients who have such a severe dyspeptic symptoms that they cannot eat in the morning. So there is many of the principles of what I want to discuss. Many of the treatment interventions do not just apply to severe cases of pseudo-obstruction, but would apply also to milder forms, right? Milder forms of motility disorders that you will be more likely to encounter in your practice. So how common are these problems? Motility disorders are actually fairly common, and they take into account for a significant subset of patients with intestinal failure. I'm Italian, so I show you data from the Italian registry, but you can see here that about 15% of all patients who were on TPN in this registry published from the Italian consortium had a motility disorder as the main reason why they had intestinal failure, why they were not able to eat and require TPN. And what's interesting is that if you look what happens over time, among patients with intestinal failures, if you compare patients with classic short gut and gastroschisis and other anatomical reasons to have intestinal failure, many of them eventually are able to get off TPN. This is the proportion of patients remaining on TPN. So many of them eventually are able to be weaned, are able to make it on oral feedings. But if you look at patients with pseudo-obstruction or with a motility disorder causing intestinal failure, those patients will stay on TPN, right? That doesn't go away. There are no cures short of intestinal transplant for patients with pseudo-obstruction. We can make them better, we can improve their quality of life, but we cannot always be able to get them off TPN. And if you look at the indication for small bowel transplant, that's a case series from Pittsburgh that has the largest experience for small bowel transplant. If you can see, 210 small bowel transplant in Pittsburgh, you can see that motility disorders, either by themselves or combined with other forms of short bowel, do account for a very significant subset of patients with the requiring transplant. So a very significant subgroup of patients requiring long-term care. All right, what else do they do? Once you have a motility disorder, are you at higher risk for other complications? One that comes up actually not infrequently is volvulus. You have these patients with massively dilated loops of bowel, you have a dysmotile bowel, and you are at risk to develop a volvulus, which is often very difficult to diagnose. This is another case report of a volvulus in a patient with intestinal motility disorder. It takes a while before you can recognize. In this case, for 4 days, which could be catastrophic for a patient, obviously, with a complication that leads to ischemic bowel. It's very difficult because these patients are already very distended, already have dilated loops of bowel. So having a change in the clinical presentation, in the clinical symptoms should raise a flag, should raise the suspicion of something else happening and makes you worry about, for example, a complication like a volvulus, a colonic volvulus. What else? They have a lot of problems with ostomy. You know, I drive my surgeons crazy with, complaining about, some of my patients with chronic intestinal pseudo-obstruction who have ileostomies and they collapse and they have all sorts of issues with their ostomies and they, I send them back to them to tack it, to do all sorts of revisions of the ostomies, but that remains a significant source of angst for many of our patients. Sometimes they're very reducible and they learn how to live with them. Other times they require further surgical interventions. All right. So how do we diagnose motility disorders, right? There are things that we've been using for many, many years. This is not new. Manometry, right, has been the main diagnostic test for many years. So manometry is a fairly invasive test, right? Requires inserting a catheter that has pressure sensors throughout the catheter itself and measures pressure changes at different levels, and you can tell, how strong the contractions are and how well coordinated or uncoordinated they are. And, we can place the catheters pretty much anywhere in the GI tract. You go from above, you go from below, and you can study a lot of things. You can tell if somebody has a neuropathy, for example, a lot of uncoordinated contractions, or myopathy, myopathic disorders causing the bowel not to contract well, causing the bowel to have a less effective proportion of peristalsis. So you can tell that, right, with a manometry. You can tell even better, even more importantly, what's normal. In the colon, for example, we have a pattern of contractions that has been established. And I actually claim that colonic manometry not only has become a routine test, it's not experimental anymore, it has a CPT code, so it's a test that should be available in any major medical center. You do have it available here, but it's probably the most helpful of all the manometry tests, in my opinion. So what does it tell us? Manometry tell us whether or not there is a motility problem, right? Sometimes you're not sure. The symptoms are such that you suspect a motility problem, but sometimes the tests, do not seem to fit. So this one could be like, the big convincer is the test that tells you whether or not indeed the symptoms are due to maternal hypervigilance or to a true underlying motility problem. You may diagnose other things. There is a condition called rumination syndrome that presents with immediate vomiting after eating that has a specific manometric pattern that, very often gets confused with the gastroesophageal reflux or gastroparesis. It tells you what works and what doesn't work. Is the colon the problem? Is the small bowel the problem? Is this patient somebody that eventually is going to need a multivisceral transplant or just a small bowel transplant? Sometimes it tells you why it doesn't work, right? It's a neuropathy, it's a myopathy. Myopathies in general are more severe. That's good, worse prognosis. They have usually a bladder involvement. So sometimes it helps to know whether or not you have a myopathy or neuropathy. And you can test drugs during the test, right? You can give a drug, you can give octreotide, you can give erythromycin, you can give bisacodyl. You can do something during the test to see if this is a good possible drug to help this child. As I said, sometimes the most important information is having a normal test. And, if you have normal manometry, you cannot have intestinal pseudo-obstruction. Intestinal pseudo-obstruction is exactly what the term says. You have a bowel so dysfunctional that makes it look like you have an obstruction. But then, when the surgeon operates, there is no obstruction. So you have to have a severely dysfunctional bowel. If you have a normal test, like people report in these cases, you cannot have it. Then you start worried about other things. You worry, for example, even things like Munchausen by proxy. When I was in Pittsburgh, I still remember having the surgeons doing a transplant, small bowel transplant, in a patient that did not have any disease, was a victim of Munchausen by proxy. That came out to light only in the post-op. In the meantime, the patient had lost their bowel. So you want to confirm a diagnosis of pseudo-obstruction, especially if you don't have the classic dilated loops of bowel, the classic, something doesn't quite fit right in your mind, you're worried about maybe over-reporting so that's always something to keep in the back of your mind. So a normal test sometimes can be as informative as an abnormal test. What else do we have? That manometry that I show you, the little squiggle there, there are things of the past. They've been around for like 30 years. I think we got as much information from those. We now have a way to diagnose manometry that is a little bit better than the classic little lines going up and down. When something goes down, is a relaxation. This is, for example, an anal sphincter that you increase the balloon pressure in the rectum and you have a relaxation of the sphincter. That's the way we used to look at it. Now we have a much more colorful way to look at manometry. You have high topography or high resolution manometry in which you actually don't have to move the catheter. You put it in, you have many, many sensors. You have dozens of sensors spaced very closely apart, and now you have a much more specific, much more precise way to look at manometry. You can reconstruct three-dimensionally the anal sphincter, the colon diameter, and so on, and you can tell much more easily a normal sphincter like this one, in which you have the green, low pressure opening up in between the baseline red pressure. So this is a normal sphincter, and you have a patient here with anal achalasia or Hirschsprung disease that has no relaxation of the anal sphincter. The pressure stays high. The pressure stays in the 60, 70. So we can do that in the esophagus as well. We can diagnose subgroups of achalasia. We can actually diagnose better even colonic abnormalities. We can tell you exactly, I can tell you exactly to my surgeon what part of the colon works and what doesn't work by looking at this. This, for example, is a normal test in which you have beautifully propagated contraction. That's pretty exciting. I like to look at these things. Or you have somebody that has a very abnormal peristalsis. You have no propagation of the peristaltic waves. It becomes simultaneous. It doesn't move down in a temporary way. It just stays the same over time. So there is no peristalsis there. And you can, as I said, you can have hundreds of recording sites to reconstruct three-dimensionally the colon. And I can tell my surgeon the last 38 centimeters of the colon that don't work. We have, the ability to now do segmental colectomy, subtotal colectomy, depending on what the patient needs in the cases of intractable constipation, based on a very precisely mapped motor activity of the colon. So this has been a tremendous improvement, tremendous new progress in our ability to study motility. What else? There is a less invasive, very child-friendly, user-friendly technology called the wireless motility capsule, or the smart pill. It's as big as a video capsule, that you can use a capsule for endoscopic pictures, right? You can swallow it and that takes pictures. This one does not take pictures. This one measures pressure, pH, and temperature throughout the GI tract. And it's been FDA approved for use in adults, and it has a CPT code, so it can be used. And we have used it in children as well. They need to be children old enough to be able to swallow a fairly sizable capsule. As I said, it's as big as a video endoscopy capsule, so it's like a very large vitamin pill. And when you swallow it, that's what you get. You get a line here in green, which is a pH. So you swallow it. You need to stop your PPIs and H2 blockers, and you can tell that you are in the stomach because the pH of the stomach is 1 or 2. And then you empty the capsule, and the pH of the duodenum is 7 or 8, and you know that that's your gastric emptying, the time that the capsule stays in the stomach. and then he keeps moving, and then once he reaches the colon, by going from the terminal ileum to the colon, there is a drop in pH. The colon has a lower pH than the terminal ileum, so now you know your small bowel transit time. And then by measuring the pressure or the temperature, you know when you expel it, because the temperature of your toilet water is lower than your body temperature, unless you have one of those very fancy warm water toilets. So that you can tell exactly gastric emptying, small bowel transit, colonic transit, and you can measure pressures as well. And that's disposable, and you wear a box that collects all the information, and then you mail in the box, and then you can download it and tell how long does it take for things to go through. As I said, I didn't know that, but the large bowel of the cecum has a pH that is lower than the small bowel due to the increased bacterial counts and fermentation of the colon. So you can tell when things drop from the small bowel to the large bowel. And that's, for example, a patient that had this test, and you can measure 525 minutes, and then you can tell whether or not something is normal or abnormal. Here, in blue, is a drop in temperature. That means you have expelled the capsule. And we use it, we tried, we have published a study that showed that actually it correlates pretty well with gastric emptying study done by nuclear medicine. And for some characteristics, it's actually even more precise than intraduodenal manometry to determine, for example, some specific motility pattern. So you can use it as a screening test. I don't use it for my more specific, more sophisticated motility evaluation, but if you don't have manometry available to you, if you just want to use an easy test that doesn't bother the family and is not particularly invasive, you can do it. Everything is completely normal. Maybe they don't need a manometry. If they expel the capsule within a day or two, they probably don't have a significant motility issue. What else? Nuclear medicine, very non-invasive, right? Every large division or department has a nuclear medicine department. Talk to them. Show them the limitless possibility of nuclear medicine, not only for the gastric emptying, but also for the colonic transit. We know what's normal. We know that we need to use a standard test meal. We know that you need to go 4 hours. Don't stop after 1 hour. Who cares what the gastric emptying is after 1 hour? Nobody eats every hour. Some of my friends, some of my kids do. But in general, we want to know after 4 hours. If somebody with gastroparesis needs to have a lot left in the stomach after 4 hours. And if they do, then it causes symptoms. But after 1 hour, all of us have a lot of food. Doesn't matter if it is 70% left in the stomach or 60%, right? So go to 4 hours. Anything left in the stomach, more than 10%, is gastroparesis. And Miguel Saps has done a study, show that extending the gastric emptying study to 4 hours does increase the sensitivity of the test. So go 4 hours. Don't stop early. Many nuclear medicine departments stop too early. You don't have to have a child or a patient under the gamma camera for 4 hours, right? You just ingest a meal, the test meal, scrambled eggs, or if they're allergic to eggs, there are some substitute meals, and then come back after 2 hours to take a picture, and after 4 hours to take another picture. Very good screening test for motility disorders and the gold standard for gastroparesis. Colonic scintigraphy. Why not use nuclear medicine to study how the colon works? Once again, we have done this study. It's very easy. You swallow a capsule that releases radioactivity once you get to the terminal ileum, a pH-dependent capsule. Then you have radioactivity being released, and then you measure, radioactivity in different areas of the colon, and you get a picture like this. Everything in the rectum after 48 hours, normal, or things left in the right side of the colon or transverse colon after 48 hours, abnormal. Easy. Take 2 pictures. You need to come back after 48 hours, 24 hours, then 48 hours. So a little bit less convenient for the family. But I'm sure that if you ask your nuclear medicine department to use this test, they will do it. They did in our place. It's not standard everywhere, but the Mayo Clinic has used it forever. Not a bad test to use as a screening test for patients in whom you are worried about an organic disease causing constipation, a motility disorder causing constipation. Easy to do. And we compare it to manometry, and actually, for some things, maybe even better than manometry. In fact, it's a better life, normal life situation, right? You don't have, for the manometry, you do a colonic clean out, you do a colonoscopy, now you have a catheter in your colon. Really, you stay in bed for 8 hours, 6 hours, so it's very non-physiologic. With the colonic scintigraphy, you walk around, you eat, you have a normal life for 2 days, you just take a couple of pictures. So very user-friendly and much more physiologic. Okay, I always like to do some public service announcement when I give my talks, just to wake people up. I want to remind you, please do not swallow chewing gum. All right, that's always takes a little while. Why? All right. I want to remind you that there is a differential for motility disorders, right? There is not everything is congenital and idiopathic, and there are things you actually can do to help some of the patients, especially in acquired form of motility disorder. I went from one extreme to the other. I went from the point that I always told my surgeons, don't even bother getting biopsies or tissue from these patients because we never find something that helps the patient. Now, actually, you do have the ability to get full thickness biopsies, either laparoscopically, or some people now, they're using perendoscopic POEM as well, in the ability to get full thickness biopsy in the stomach. Maybe a team, besides doing POEM for achalasia, may want to do this as well. You can go, from the mucosal side and getting full thickness biopsy from the stomach or from the colon, and sometimes you find things that can help you. You may find an acquired form of an autoimmune disorder, destroying your ganglion cells. You can have a ganglionitis. So in acquired forms of motility disorder, it does pay off to get a full thickness biopsy. You can have some hints that you may have a mitochondrial disease. So there are things that you can actually do something about. In this case, reports of ganglionitis or myositis due to an autoimmune disorder or to an allergic disorder, actually you could treat that. You could treat that with immunosuppression, with elimination diet. Those were patients who then got better once they were immunosuppressed. So I actually switched my position on this. I actually do now recommend getting tissue from patients who have acquired form of severe motility disorder, especially because it can be done fairly non-invasively. And if the surgeon goes in laparoscopically, I ask to get a couple of biopsies from the small bowel and a couple from the large bowel, if they can. And then you need to have the right pathologist that does the most sophisticated staining of nerve and muscle cells to figure out what's normal and abnormal. All right, treatment. The last part is all about treatment, which is really probably what most people want to know about motility disorder, right? What can we do for the treatment? You try everything, right? There is no disease that is exactly the same as the other one. And at the end of the day, if somebody is on TPN, you have to try everything to get them off TPN. So the proverbial kitchen sink. I never quite understood this metaphor, but it's a commonly used one. So you throw them everything, including the kitchen sink. So you try everything, including high doses stimulant laxatives, which is one of my pet peeves. I see a lot of patients coming to see me for colonic manometry test, considering a cecostomy, considering a colostomy. They were never been even tried on high doses Senna or bisacodyl. I don't know why. There is a hesitation in using stimulant laxative with this unfounded fear of causing dependence or causing damage to the colon. Stimulant laxatives are fine when they need to be used, but you always have to confront families that, parents who have done the research clinic. You got people that, for some reason, I've heard all over the place that it's bad for you to be on a high dose of laxative. So sometimes I do a manometry test and I just tell them to use more, or what they were already on, or sometimes they're just on stool softeners. I tell them to use daily stimulant laxative. Is that what it takes for them to avoid a colectomy or a cecostomy. So what are we going to try? The new things are antibiotics, not just erythromycin, but we'll talk about others, octreotide, pyridostigmine, linaclotide, and I will not talk about it, but baclofen is another medication that people use for refractory gastroesophageal reflux, which is the only medication that can help the lower esophageal sphincter to relax not as frequently. So it's the only prokinetic that helps gastroesophageal reflux. And betanethol, which is a medication that's been around as long as I've been alive, that has been, is a cholinomimetic medication actually that is encountering some resurgence as well, some reappraisal. So it's still around. So let's talk about these things. Erythromycin is the most potent prokinetic for the stomach. Only works for the stomach, doesn't do anything for the esophagus, doesn't do anything for the colon, but it does help the stomach. And there is this myth out there that low doses erythromycin should be used. Yes, low doses erythromycin works well if you have a normal working stomach. But if you have gastroparesis, push the dose. 5, 10 milligrams per kilo per dose, 15 milligrams per kilo per dose. As long as you don't have nausea and diarrhea or other symptoms, you probably have not reached the top yet of what the dose should be. So the regular, if you look at a textbook, they tell you to use 2, 3 milligrams per kilo per dose. It's going to work only in patients with very mild forms. I push the dose to antibiotic dose. What else? You treat bacterial overgrowth. Bacterial overgrowth is a very, very common consequence of this motility, right? There is a function of the small bowel that is called housekeeping. There are propagated ways that clean out the bowel from undigested material and bacteria. And if you don't have good motility, those bacteria do not get clean. And uniformly, patients with pseudo-obstruction have gas chambers from dilated loops in which bacteria just produce even more gas. They stretch the bowel even more. They cause inflammation. Bacterial overgrowth causes mucosal inflammation. Mucosal inflammation causes increased permeability. If you have increased permeability and you have a central line, you are at high risk for central line sepsis. So treat bacterial overgrowth aggressively. Everybody always asks me, what is my recipe? I don't have one. I do, 1 week of metronidazole, 1 week of rifaximin, 1 week of augmentin, and then sometimes I throw in 1 week, of an antifungal as well if I'm using a lot of antibiotics. So, you rotate antibiotics, and usually the family can tell me, I was much better with this specific regimen, and then we stick with that a lot longer. And when you treat bacterial overgrowth, the other thing you can use is use augmentin. Augmentin is the best prokinetic for small bowel. So erythromycin for the stomach, augmentin for the small bowel. We published studies that show that it stimulates propagated contraction. So this is the time where the infectious disease people in the audience shiver and have seizures over hearing me that I treat all my patients with erythromycin and augmentin. And yes, I'm very aware of the risk for C. diff. I'm very well aware of the risk of bacterial resistance and line sepsis from yeast, from chronic use of antibiotics. But for many patients, use of augmentin, use of erythromycin, sometimes even in combination, makes the difference between being on TPN and being on enteral feed. As I said, this is the most effective medication for small bowel, is motility. Doesn't do anything for the stomach, but helps the small bowel. And we tried to figure out, really the clavulanic acid, maybe we should give clavulanic acid to everybody, or is it amoxicillin? In the lab, we've done studies in the lab, and one of our fellows, Dr. Sikora, showed that in muscle strips of the duodenum in the animal model, the amoxicillin is what seems to have, obviously, the effect on the contractility. So maybe we'll be able to use amoxicillin. I still use augmentin as my prokinetic of choice in the small bowel. Octreotide. You guys familiar with octreotide? It's a medication that obviously has been approved for different things. It's for some neuroendocrine tumors, and actually is a medication that inhibits pretty much everything. Inhibits actually gastric-emptying, inhibits gallbladder contractility, inhibits growth, but it does stimulate small bowel and also decreases pain threshold, so makes you less sensitive to pain. It's a hypoalgesic agent. So if you have, for example, an ostomy that has a lot of output, so this is an anti-secretory agent. So it helps with the small bowel, decreases secretion, and decreases pain. Many of these patients have pain as well. And the octreotide may help from all these different point of view. It's very effective. The problem is that it needs to be given sub-Q or IV, so not very user-friendly. There is a depot form that I never use, and often I get asked about, so I still use sub-Q 2-3 times a day injection of octreotide in my patients with bad motility. It helps with scleroderma. It helps with the chronic intestinal pseudo-obstruction. Pyridostigmine, it's another off-label use. This is always the part where I remind people, this is all off-label use of medications, right? But it's what we have to help patients with motility disorder. Pyridostigmine is a medication used for myasthenia gravis, completely different condition, right? It inhibits the reuptake and breakdown of acetylcholine. So it makes more acetylcholine available to the muscle. So it does help patients with pseudo-obstruction. It does help patients with motility disorders. And it's been shown that, in patients with intestinal pseudo-obstruction, this, small case series, nobody's going to do a randomized controlled trial of pyridostigmine in pseudo-obstruction. Not enough patients. These patients need all the help they can get. But at least in this case series, it was very helpful. And I use it. This is the oral form. We use neostigmine, which is the IV form for colonic pseudo-obstruction, sometimes in the ICU, sometimes patients with something called Ogilvie syndrome, where you have a big dilated colon. So we certainly have to think about pyridostigmine as well. What else do we have? We have a couple of new medications that have been approved by the FDA for use in adult women with chronic constipation and irritable bowel. One is lubiprostone. It goes under the market name of Amitiza. It's been around now for many years. And the other one is more recently approved, something called linaclotide. It goes under the market name of Linzess. Linaclotide stimulates motility by stimulating secretion. You secrete, you work on the cGMP enzymes, and you have an increase in secretion and actually some effect on afferent pain fibers as well. So more secretion, more and more effective colonic peristalsis, probably due to the stretching of the wall from the secretion, and decreased sensitivity from pain fibers. Hence, it works in irritable bowel and in chronic constipation. So I find it to be very helpful in adolescents with constipation. In adults, has been used now for 2 or 3 years, was FDA approved in 2012. And the main caveat is that it does have a black box warning. It says do not use in children at all, in anybody less than 17, and especially do not use it in people less than 7. The main reason for this warning is that it causes diarrhea. If you use enough, you're going to cause dehydration, and there were some neonatal rats in the animal model that got really dehydrated and in kidney failure, and so, but being something that is a laxative, obviously if you give enough, it's going to cause diarrhea and dehydration. So I use it in adolescents, and I've actually been very satisfied with the outcome, but I will not use it in anybody younger than 7. And these are the data from adult study that shows that in irritable bowel and abdominal pain, constipation predominant irritable bowel, linaclotide was more effective than placebo. What about domperidone? You guys familiar with domperidone? Anybody that works or has ever worked outside the United States knows domperidone. It's approved everywhere in the world. It's available in Canada. It's available in Mexico. I left Italy in 1988. It was already available in Italy at that time. Is in some way a metoclopramide that doesn't cross the brain barrier. We don't use Reglan anymore because of the black box warning, and we don't use it because of the fear of side effects. But this is a safer way to provide similar mechanism of action, has been approved in most countries for treatment of gastroparesis and severe nausea, but is not FDA approved for use in the United States because of perceived lack of efficacy. They were never able to show that it was better than placebo for diabetic gastroparesis. So we have an IND. We're allowed to use it in Columbus, in our clinic, with the FDA permission, and many places they get it online because it's very easy to get online, and you want to probably monitor those patients fairly closely. Botox. I'm a big fan of Botox, not only for my perfect skin tone, but also because it is a low-risk, possibly fairly high-yield interventions in patients with motility disorders. You can inject it in pretty much any sphincter. It's going to help it relax. If you inject it in the pylorus, which is probably easier to do than taking biopsies, you're going to have an effect on nausea, an effect on gastric emptying. And people have done studies and looked at, you can see here, you inject 100 units, 25 in 4 different quadrants. And this is a case series from Sam Nurko group in Boston showing that anything from vomiting to nausea and to feeding intolerance and abdominal pain improve. Doesn't take much. As I said, adds 1 minute to the procedure time. And people have done in the anus as well. You can inject Botox in patients with Hirschsprung disease. They continue to struggle with evacuation of stools. In patients with anal achalasia, very easy to do. You inject, once again, 25 units in each quadrant. And in the variety of different reports, seems to help with defecation. So if you have somebody that has failed everything else, all the medical treatment, Botox injection in the anus, which is used in adults, for example, for chronic fissures and for many other interventions, may be very helpful. This is another study that we published more than 10 years ago, showing that for some reason, the benefits last even more than the classic 3 months that you would expect. Some patients continue to do well for like 8 months, 10 months, 12 months. Not sure why. Maybe they just now, they empty the rectum better, now they're able to relax the pelvic floor better, maybe the rectum is not dilated anymore. But I have patients that come to see me once a year to get a Botox injection in the anus. They can tell when it's time to have another one. The same for the pylorus. Once again, not a lot to lose. Worst can happen in the anus, you get a little bit of fecal incontinence. I've never seen that happen, but it could if you make the sphincter too weak. What about surgery in pseudo-obstruction? You need to shorten the gut, right? If the gut is this motile, you don't want to make it go through yards and yards. You make it as short as possible, so that even if there is a little bit of peristalsis, if you have nothing is going to work. But if you have a little bit of peristalsis, if you have contractions that maybe are half the normal amplitude, by shortening, by feeding in the jejunum, we don't need the stomach, right? And diverting in the ileum, you may help them. So I go as far as saying that every child with pseudo-obstruction on TPN needs a gastrostomy and an ileostomy. And I cannot tell you how many times having an ileostomy makes a difference between being on TPN and being off TPN. Just that. It's always a lot of resistance from the parents in getting a diverting ostomy, but it pays off in the long run. And then once they're off TPN, you can restudy the colon eventually, 2, 5 years out, and see if you can you have to reconnect them. Antegrade Enemas. This is one of the things that have changed the way I practice pediatric gastroenterology. In patients with severe constipation, especially when fecal incontinence is part of the phenotype, you may want to give strong consideration to the placement of an antegrade enema, either a cecostomy or an appendicostomy. The surgeon can create the so-called Malone appendicostomy, in which you can actually just put an opening within the belly button that you can catheterize and flush the bowel from the top down. If the problem is in the colon, why take things by mouth? Why taking laxatives that will work at an unpredictable time? Why not having something directly in the cecum that you can cannulate, and then, especially if you add the stimulant to the cleansing solution, in 20 minutes, you're done. 30 minutes, you're done. You sit on the toilet, you put some normal saline with some glycerin or bisacodal, you empty your colon. And you're not going to have an accident for the next 24 hours because it takes about 24 hours for the colon to fill again to the point that it starts leaking. We have more than 100 patients that have this intervention. Our interventional radiologists actually do it, but the surgeons can do an appendicostomy that is cosmetically even less intrusive than a cectostomy. It looks much like a gastrostomy tube, right? You've all seen gastrostomy tubes, but for some reason there is a lot of resistance. When I go around the country talking about cectostomy, they tell you, are you crazy? Do surgery for constipation? We can fix every constipation with medicine. Okay, if you can do that, that's fine. Keep using your medicine. But if you are like me, that's the patients that have not been able to be fixed by medical, behavioral, and dietary interventions, consider a cectostomy. For some reason, I always make the example that gastrostomies, we are the ones that have to convince the parents to get a gastrostomy, right? Patients doesn't eat well, malnourished, failure to thrive. Sometimes family is very resistant to a gastrostomy. They want them to eat. For cectostomy, the family is desperate. They had this problem for 6, 8 years, sometimes soiling, low self-esteem, bullying in school, and they want something new. They are tired of getting polyethylene glycol and stena. Consider a cectostomy. Sometimes it's the family, it's the doctor that is more resistant than the family. Nothing to lose. If it doesn't work, you pull it out, much like a G-tube, right? It closes by itself. What about pacing? You probably heard about this, right? There is now the ability to pace the stomach, much like we pace the heart. We cannot pace the intestine yet. The bowel is much more sophisticated organ compared to the heart. The heart is just pumping, it doesn't do anything else. Stomach has to break things down and expose to the mucosa, absorb them in several yards. So we cannot pace the entire bowel yet, but for the stomach, we can pace the stomach. Stomach is not that big, and even if you don't pace the stomach, even if you don't improve gastric emptying, you can actually improve nausea and symptoms. You have a high frequency stimulation of the stomach that stimulates afferent nerves and decreases nausea. For nausea especially, gastric pacing is sometimes a miracle intervention. It's done in children of any age. This was done in the Netherlands, in Sweden, in children as young as 3 years of age. Has some benefit in those patients. So we have now published a variety of papers reporting our experience in Columbus, showing that there is a benefit pretty much on every symptom. Anything from nausea to early satiety, bloating, vomiting, burning, all upper foregut symptoms improve with gastric pacing. And we can do a temporary one as well to see if it's going to work. You can do endoscopically. You clip the wire to the mucosal side of the stomach with a scope, see if the child gets better, and if it does, then you proceed with a permanent pacing. Yes, of course, it's a big deal. In surgery, you're going to have now a metallic box under your skin, connected to the serosal side of the stomach. Every 5-7 years, you need to change the battery. You may be limited to some of the contact sports that you have to do, but I have to tell you, I did a 180 in this. I was very skeptical about gastric pacing. I thought it was all placebo, and this is patients that I just give them a good pep talk. I'm going to make them better with their nausea. I've seen patients that are cognitively impaired, that have no idea what we just did to them, that stop vomiting. I've seen patients that we forgot to turn the pacer on, and they didn't feel better, and then once we turned them on, suddenly they felt better. So I'm actually have become a believer. We need to select patients very carefully. We have done the pacer in patients with an eating disorder. It's not going to fix an eating disorder. People see the pacer as validation of the symptoms. They hang on to the pacer. Everybody comes and wants a pacer. The easy fix. That doesn't work well for many of the more complex biopsychosocial patients that we see, but it does help in some patients, and that helps especially, as I said, with nausea, regardless of whether or not you have underlying gastroparesis. What about pacing the colon? Central nerve stimulation has been around for a long time. The urologists have used it for bladder dysfunction, for urinary incontinence. And then by using in those patients, they found out that the constipation improved. They found out that the fecal incontinence improved. So this is actually a device that we now use in patients with elimination disorders, both urinary and fecal, or sometimes even just for patients who have refractory constipation or fecal incontinence. And in a pediatric case series done in the Netherlands, people found that the constipation score, for example, dropped significantly after the sacral nerve stimulation was placed. So a lot of new things you can do, right? There are new medications, there is the Botox, there is the pacing, the gastric pacing, there is small bowel pacing, there are surgical, colonic pacing, there are surgical interventions you can do. So what else is left? It's just a cure, right? I know that here in town, at Georgetown, they do a small bowel transplant. I like to buy a bowel. That would be the definitive solution for those patients. Still not the greatest outcome. Patients with motility disorder just do as well or as poorly, if you want, as any of the other patients that have a transplant. So about, a 50% organ survival or patient survival at 5 years. So for the patients in whom you are experiencing complications from TPN, recurrent sepsis, recurrent thrombosis, or liver disease from use of TPN, then transplant remains a possibility, but that's a very small subgroup of patients. I'm going to finish here, and I think I have 5 minutes left for questions. I will be happy to entertain any questions you may have. Thank you for your attention. Dr. Khan.
Well, thank you for coming.
Oh.
I always look forward to hear your conference. Very good. I'm very glad. I'm very glad that you come here and talk about augmenting and erythromycin, because ID infections always criticize me about that in my patients, and that how come I use. I don't know how to use the to convince this that is not a problem. What I found here, listening to your conference, is that many of my short bowel patients have problems with motility, specifically gastroschisis, intestinal atresia, and non-segment Hirschsprung disease. So I started looking for gastric-emptying, looking for the transit time in these extreme short guts, and I found that they have ectasis in many of the loops. So in one patient with long-segment Hirschsprung disease with an ostomy, only with 30 centimeters of gut with persistent diarrhea, I start using augmentin, and the diarrhea stops because he starts having a normal motility. So it's really useful. One of my questions now is prucalopride. Now it's a new medication that we don't have here, but I have been starting using some patients that live in Canada and buy the medication.
I was wondering how you get your hands on prucalopride.
Or by computer. Now I start learning how to use it and bring it on here. And I have
Don't recommend that, but.
But I have patients who have very refractory intestinal dysmotility in short bowels that has a lot of improvement with this. Boston wrote a paper about prucalopride and constipations. So, have you had any?
So I was actually on that paper that looked up prucalopride, which is a serotonin receptor agonist, and is approved for use in Canada and in some European countries. And the main efficacy seems to be on the colon, but it may have some efficacy in the upper GI tract as well. So I do not have a lot of experience out of that initial study that we did a few years ago. I had the impression that it was an effective medication, much like tagacerod, another medication that has disappeared and now it was taken off the market by the FDA. I don't know if and when the FDA will approve it. So I don't have a lot of personal experience, but I would think, as I said, you try everything for these patients, because if you can get them off TPN, the morbidity is going to reduce dramatically. And I also share, I sympathize with your difficulty in the patients with a short gut. Now you have an anatomical and a physiologic, you have both function and anatomy that is abnormal. And for those patients, all bets are off. I mean, you cannot study the gastric-emptying on the small bowel transit because now the bowel is like, 80 centimeters long. I mean, everything is different. So I'm not surprised that augmentin helped in those patients because you have effect on bacterial overgrowth, the antibiotic effect, and the prokinetic effect as well. But I don't have a lot of experience with prucalopride. I wish I did. I've not been able to get it yet from Canada.
Some patients who have been refractory to erythromycin and with leaking and leaking, there is
Good to know. Thank you.
Thank you very much. I'm over here. That was a great talk. I wonder if you could speak a bit to cerebral palsy, where there are issues both with constipation on one end and gastroesophageal reflux on the other, and how you...
Yeah, I mean, that's, once again, all bets are off in that population because you have so many other variables, right? And now you have the diet variable. You have the diet with no fiber often. You have often medications like baclofen, which can help reflux but can make the constipation much worse. Then you have the variable, the spasticity and the seizure disorder can make reflux worse. So if you want to separate those two things, reflux from the constipation, for the reflux, many of those patients, to be honest, end up getting a fundoplication. And I do not hesitate. Nowadays, fundoplication, especially done laparoscopically, is not as huge of a big deal. And especially if they don't have a lot of oral intake, I'm not too worried about, an antegrade problem with the fundoplication. For the constipation, I treat them much like I treat anybody else. Once again, when I talk to pediatrician or hospitalists, I always remind them that it's okay to use stimulant laxative, and some of these patients may do better with the high dose of Senna. I don't think anything bad will happen if you push the dose. And sometimes the Senna is what makes the difference. Bisacodal, unfortunately, comes only in pills, and it cannot always be given to this type of patients. Other families don't mind retrograde enemas. Getting an enema, a classic fleet enema every 2 days or so. Sometimes it's predictable. When it's convenient for the family, works well for them, doesn't create a big mess with a sudden explosion of stools. That may work just as well. Benny, Seema wants to talk.
I'm sure you have something very,
I do.
to say. Everyone wants to show respect of everyone's time. But Benny, please come to the atrium afterwards. We're going to have some tea, and anyone else who wants to talk to Carter. Carter, thank you very much. I just wanted to make a quick announcement, and I want to thank the Friedman, Dr. Friedman, Mr. Friedman. Harry Friedman was Richard Schisgall's wife, and we really appreciate your support and continued support of the Schisgall Institute.